Hello, everyone, and welcome to today's live broadcast, Laboratory and Clinical Benefits of Rapid Blood Culture Diagnostics, presented by Esther Babady, PhD, Director of Clinical Microbiology Operations, Memorial Sloan Kettering Cancer Center. We are excited to bring you this educational webcast presented by LabRoots and sponsored by OpGen. OpGen is uniquely positioned to address the rising antibiotic resistance crisis and is harnessing the power of informatics and genomic analysis to provide complete solutions to protect patients in hospitals and healthcare networks. I'm Julie Simmeroff of LabRoots, and I'll be your moderator for today's event. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know that you're having a problem. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. Now, I'd like to introduce Dr. Esther Babady. Dr. Babady is the Director of Clinical Operations for the Microbiology Laboratory Service and an associate attending in the Department of Laboratory Medicine at Memorial Sloan Kettering Cancer Center, MSKCC, in New York City. She also serves as the Director of the CPEP Clinical Microbiology Fellowship Program at MSKCC. For Dr. Babady's full biography, please visit labroots.com. Please join me in welcoming Dr. Esther Babady. I will now turn the presentation over to her.
Thank you, Julie. I want to get started by thanking OpGen for organizing this educational webinar and inviting me to discuss a topic that I know is of interest to many of us in the clinical laboratory, and that is the rapid diagnosis of sepsis. So my goal today is to make sure that at the end of this presentation, you as a learner should be able to discuss what sepsis is and which laboratory method is available for rapid diagnosis, as well as describe the benefit of rapid blood culture diagnosis on both laboratory workflow as well as clinical outcome, because, at the end of the day, these are the patients that we take care of, and we want to make sure everything we do benefits them. To get started, I wanted to start maybe with a question to get a sense of what everybody sort of knows about sepsis. So this is a poll question. Which of the following statement is true about sepsis? Is it that A, it's a leading cause of hospitalization? Is it a leading cause of inpatient mortality? Is it the most costly cause of hospitalization? Is it the easiest syndrome to diagnose, or is it all of the above? I think you guys are going to have about 30 seconds to answer the poll, but I'm going to keep moving, and we'll discuss the result in a little bit later. So, to just maybe frame the discussion a little bit better, I wanted to tell you the story that is a story that's very familiar to us living in New York State, and that's the story of Rory Stoughton. As you can see in this image, Rory Stoughton's parents were at an NBC show about a year or two ago. But Rory Stoughton was a healthy 12-year-old boy who basically was playing basketball in the gym at his school and fell and scraped his arm. His coach saw that he got hurt, and so just put a Band-Aid on his arm and sent him home, which is like a simple thing to do. Rory wakes up in the middle of the night, not feeling well, and so his parents set up a meeting, an appointment for him to see his primary care physician the next day. They go to the physician the following day, and same scenario. The physician looks at him, he scraped his arm, he's a little boy, that's not a big deal, gives him some painkiller and send him home, thinking that the kid only had like a GI bug and a scrape. In the middle of the night again, Rory wakes up, not feeling well, so his parents decide to take him to the emergency room at one of the major hospitals in New York City. And the same scenario appeared in the emergency room, where the physician looked at him, a relatively healthy boy with a scrape on his arm but not feeling well, so observed him, gave him some painkiller, and sent him home. But he was not getting better, so eventually he came back again to the emergency room. At that point, he was admitted in the ICU. And as you can see by the slide, that he didn't actually make it out of the ICU. He was diagnosed with sepsis pretty late, and he succumbed to that infection. So this is one of the stories that's really sad, and I think many of us can relate in the sense that we've had patients who came to the hospital and the diagnosis was delayed for one reason or another. In New York State, the story of Rory ended up being taken pretty seriously, so much so that New York State became one of the very first states where there is regulation for the diagnosis of sepsis. So it's a mandate that every hospital in the state of New York has protocol in place to recognize sepsis and recognize it early. And I think many of us are now very familiar with this sepsis bundle. And so many of us have to make sure that when a patient presents to the hospital, they have suspicion of sepsis, that this is taken care of very quickly to prevent things like what happened to Rory from happening again. All right? So we can look at some of the results. I don't know if you guys can see them, but the result from the poll shows that many of us think that sepsis is the leading cause of hospitalization, leading cause of inpatient mortality, most costly, and easiest syndrome to diagnose, because the majority of us picked all of the above. And as we go through the presentation, we'll discuss each one of these options and determine which one is actually the correct one. So thank you guys for your participation. All right. So let's talk a little bit about sepsis. I think we use the word pretty commonly, but what does that actually mean? Until recently, sepsis was considered like a syndrome that occurs in a continuum. And that continuum will start with infection and end up with septic shock. However, in more recent data and report, sepsis is really not so much a continuum, but many of these syndromes that we're going to discuss sort of occur either simultaneously or not necessarily in one after the other. But two things that are very important to know about sepsis is that, one, you do have to have an infection. And because we have challenges in diagnosis of infection, they can either be a documented infection or a probable infection. But infection alone is not enough. Then the second component of sepsis is the fact that you may end up with SIRS, which stands for Systemic Inflammatory Response Syndrome. And essentially, SIRS means that the host does not respond appropriately to the infection. And the combination of SIRS and infection is what we traditionally think of as sepsis. So how do clinicians then recognize SIRS? There's many different clinical criteria when a patient presents to either the emergency room or the ICU, and I've listed a few of those. Including an increase in temperature, increased heart rate, or increased respiratory rate, or an increase in white blood cell count. And if you have two or more of these, there's a high suspicion for sepsis. And so these were some of the definitions that were included in one of the more recent JAMA review on sepsis. So if you remember the continuum, it started with infection and ended up with septic shock. But between those two things, we had SIRS, severe sepsis, and then septic shock. So the definition traditionally of severe sepsis was sepsis plus an organ dysfunction or tissue hypoperfusion. So essentially thinking of sepsis getting worse. Then septic shock, it's when you had sepsis-induced hypotension in spite of the fact that the patient was being given fluids to make sure that for fluid resuscitation. And those were the definition in the very last sepsis guideline that were published in 2013. However, if you fast forward a few years, now in 2016, we have new definition. And when you look at the new definition versus old, you can see that there's been a switch to make sure that like the severity of sepsis itself is really well understood, so much so that now sepsis is defined as a life-threatening organ dysfunction that is due to dysregulated host response infection. So a life-threatening infection in a patient that has SIRS. Now, severe sepsis is not an option anymore. So that has been taken out. And the reason for that is that sepsis is already a severe enough syndrome that you shouldn't think about it as sepsis that's not so severe. So we go from sepsis directly to septic shock. And septic shock is still considered to be a sepsis-induced hypotension, but an emphasis has been put now on the fact that you have a significant increase in mortality when you are in septic shock. So bottom line, the severe sepsis is gone. So when you think of sepsis, just remember that it's a very serious infection and it's life-threatening. So if we think about it in lay term, if you have to explain this to a patient, essentially sepsis is a life-threatening condition that arises when the body responds to the infection. Instead of taking care of the infection, injures its own tissue and organ. So your body is sort of turning against you. And for me, I think about it as essentially there's an imbalance in the way your body is responding to the infection. One of the things that's really important about sepsis is, yes, it is a severe syndrome, but when you think about it in terms of other infection, other causes of mortality, it's actually the sixth most common cause of hospitalization. So one of the questions in the poll was, is it the leading cause? No, it's the sixth cause of hospitalization. However, it is the most costly causes of hospitalization, accounting for approximately $20 billion or related to sepsis and sepsis care, and that was in 2011. I think one of the recent figures from 2013 quoted $23 billion, so definitely not cheap. And although it has high in-hospital mortality, it is not the highest. And with the example that I gave you of Rory Stoughton, you realize that it isn't the easiest syndrome to diagnose, but definitely the most costly. One of the things that's key about sepsis is that early recognition is super important. So there was a paper published almost 10 years ago by Kumar in the Critical Care Medicine that beautifully showed that survivals from sepsis and septic shock was directly related to the duration of hypotension before initiation of effective antimicrobial therapy. Essentially, the earlier you were able to recognize that a patient was septic, the faster you could treat them and the better they would do. So it is important for us to be able to diagnose sepsis relatively quickly to ensure that our patient survives. Which brings me to my second question. Which of the following laboratory tests is the gold standard for sepsis diagnosis? And so the poll is open, and you guys have approximately 30 seconds to answer, and we'll discuss the results when the poll closes. All right. So is it that blood culture is the gold standard? Is it multiplex nucleic amplification tests? Are they singleplex tests that are the gold standard? Is it lactate or is it procalcitonin? All right. So when you look at the surviving sepsis campaign, so sepsis there's been a surviving campaign for sepsis for the last, I want to say, about 10 years. And when you look at the more recent guideline that were published in 2016, one of the first things that has to be done when a patient is suspected of sepsis is that initial resuscitation, which needs to occur really within the 3 hours, but ideally within the first hour. And one of the lab tests that's used at that point is serum lactate. But that's only to tell if the patient, to just sort of put the patient in the right category. However, that does not diagnose sepsis because the patient can have an increased serum lactate for other reasons. So all patients with a high serum lactate then need to be screened to make sure that to just rule out sepsis. And in terms of diagnosis, then the test of choice would be, you guys guessed it, blood culture. So that's today it's still the major test used for sepsis, but it's also considered the gold standard. And I see that a few people looked at lactate, but lactate again is screening, and multiplex NAT, which we will be discussing later in the discussion, although are useful, not considered the gold standard. So according to the guideline, patients with suspicion of sepsis should get 2 sets of blood culture and other appropriate culture as needed. For example, if you suspected that the source of the infection was the urinary tract, you would do a urine culture. And this needed to occur prior to antimicrobial therapy, with the reason being that as soon as you give antibiotics to a patient, that may quickly sterilize the blood, and so a blood culture may be falsely negative. But that had to occur quickly prior to blood culture, as long as it did not delay treatment. So usually we think about 45 minutes. But as you can see on the slide, in the more recent guideline, there really isn't any recommendation in terms of which rapid diagnostic method you should be using. And primarily the reason is that we don't have enough data. So I want to show you in this presentation some of the data from our institution as well as from the literature that sort of support the use of this rapid diagnosis for ruling in or ruling out sepsis. All right. Okay, I lost my screen. All right. So, blood culture. I don't have it. Can you guys see my, I don't know. Julie, can everyone see the screen? It's just dark now. Okay. For some reason, I can't see my screen. But essentially, blood culture, it is the gold standard, but right now we know that the yield of blood culture is affected by multiple different things. That includes the use of antibiotic prior to collecting of the blood culture. So we talked a little bit about how antibiotic can result in sterilization of the blood and hence reduce the positivity rate for blood culture. Additionally, you may have the number of sets that are collected. If you don't collect enough blood culture sets, then your diagnosis is not ideal. The volume, and many of us do deal with that. We recommend usually 8 to 10 mils of blood, but we don't always get that volume. And so those are all pre-analytical criteria that are sort of outside of the lab control, but that affect really how well this blood culture can come up positive. I will need to refresh. Let's see. I'm having some technical difficulty. Just give me 1 second. I apologize for that. There we are. Now, so there's many different methods for lab testing, but in this particular talk, we're going to focus primarily on blood culture and some of the molecular methods, both amplification and non-amplification method. So the last question for us, since we are going to be discussing rapid molecular diagnosis, is do you guys think that molecular tests are the solution for the rapid diagnosis of sepsis? And in this case, we have 3 choices: yes, no, or maybe. And again, you guys have approximately 30 seconds to answer this. So while you guys answer the question, let's start discussing molecular diagnostics. When I think of molecular testing, I just think about this in terms of which sample are we actually testing. So one thing you can do, which would be sort of the holy grail of diagnosis for sepsis, right? It would be to go directly from the specimen and looking at the blood, being able to take that blood and do a test on it and get a patient result within a few hours. That's the holy grail. That's where we all want to be. However, as you may already know, most of the tests that we have right now still rely on a positive culture. So in this talk, we're going to focus on testing that is done from positive blood culture. Although it's our imperfect gold standard, that's what we have. So can we now speed up the identification of organism once the blood culture is positive? So we'll be talking about PNA FISH. We're going to talk about PCR and finish up with multiplex gold nanoparticle technology. All right, let's see the call. Maybe, and I love that answer because I think that's where we're all thinking that this is technology that's really amazing and maybe we'll be able to really answer the question of diagnosing sepsis really quickly and accurately. So let's move on and see what our options are. So starting with PNA FISH. So peptide nucleic acid fluorescent in situ hybridization. So you guys can sort of figure out why we don't spell this out all the time and just say PNA FISH. It's a mouthful, but what exactly is this technology? So many of us are familiar with DNA probe, where you have a DNA probe that can bind to either ribosomal RNA from bacterial fungi. We use that with probes that we do for microbacteria or fungal organisms and so on. With peptides, with PNA FISH, one of the things that was done was to, instead of using that phosphate backbone that results in repulsion against the target, because both nucleic acid would be negatively charged, the backbone has been replaced with a peptide. And so three things that are important with that modification. One is that because there's not that repulsion when you're trying to bind to an also negatively charged RNA molecule, that binding is much stronger. And unlike DNA probe, many times PNA FISH probes tend to be very short. All of this resulting in faster hybridization and explaining why some of this technology can give you results in a couple hours or even 20 minutes, as we'll see in this discussion. In the next couple of slides, I want to discuss primarily QuickFISH. And the example shown here would be for a set of fish where you have two targets, two options for detection. So probe A would be, let's say, Staph aureus, and probe B would be coag-negative Staph probe. So if you have a sample that's positive by blood culture and is positive for Staph aureus, you will have ribosomal RNA and plenty of it in the positive blood culture. At room temperature, nothing would happen. There will be no fluorescence, there will be no binding. So the first step in this process will be then to increase the temperature to 55 degrees. And what does this? This allows the probe to detach for the quencher and then become available for binding to the target ribosomal RNA. So now we've dissociated the quencher from the fluorescence tag and decreased the temperature back to room temperature, and then allow the probe to then go bind to the larger RNA target. And once this binds, then the fluorescence can be detected. And if there was RNA B, then the quencher B, the probe B would also be binding. But since there isn't, the probe B binds back to its quencher molecule. Okay, so this takes approximately 20 minutes and relatively simple. So you have a positive blood culture, you transfer a few drops of the blood in a tube, put it on a slide, add some reagent to fix it. You do an incubation for 15 minutes to allow for hybridization, and that's it. You look under the microscope and then see if you have green or red fluorescence depending on the kit that you're using. So this is important to know about PNA FISH, is that, as we've discussed, it's from positive blood culture only, but importantly, you have limited equipment that you need to use, essentially a heat block and the microscope, which many of our laboratories already have that. And even more impressive is that the turnaround time is only 20 minutes. And so if you think about the traditional way blood culture works, You collect the blood, you wait a few days. If you're lucky, you only wait for 24 hours. Your blood culture turns positive. You do a gram stain. In this example, you have a gram-positive cocci cluster. And that will be the report that you submit to your clinician in your EMR. And then you have to wait a day or a few days to get both the ID and the susceptibility of the result. So in this case, you'll wait maybe 2 or 3 days to tell a physician that you have a sensitive Staph aureus. With the PNA FISH, what you're able to do then is you do your gram stain, and based on the gram stain, you do your PNA FISH, and within 20 minutes, you're then able to report not gram-positive cocci cluster, but specifically Staph aureus or co-negative staph, and then wait for the census to report to the clinician. So PNA FISH, AdvanDx has made multiple choices that you have on these options for and which type of testing you can do. So for QuickFISH, you have the staph, the gram-negative, and the enterococcus, and then there's Candida QuickFISH, but that product at this point is only CE-IVD. You even have a Make Express Fish, which allows you to also rapidly determine if you have MRSA or not, and then a multitude of other choices that are regular fish, not necessarily QuickFISH. So fish has been around for a few years already. And so if you think about that and look at the literature to see, has this technology had any impact on clinical outcome? So one of the original studies was done by Graham Forrest and Christy Johnson group at the University of Maryland back in 2006. And this was done using regular fish. So what they did was looking at the impact of fish on the identification of coagulase-negative staph only. And based on the study, they could show that using coag-negative staph, regular fish, you were able to decrease the length of stay from 6 days to 4 days, decrease vancomycin usage, and decrease the overall hospital cost, which was a significant, going from $13,000 to $9,000. Additional study done in Europe showed very similar results, whereby the greater number of patients were on appropriate therapy because of the result of the PNA FISH, from 98 to 89%. You could also have faster de-escalation of empiric therapy, and less number of calls from the clinician to the lab, because instead of reporting a gram-positive cocci cluster or gram-positive cocci, depending on how brave you are with your morphology, you were reporting Staph aureus or coag-negative staph and giving the clinician enough information to make decisions. Similar results have been shown with the Candida albicans PNA FISH, and this is a study from Dr. Alexander and colleague at Duke University, showing that using Candida albicans PNA FISH, there was an overall cost saving per patient of $1,800, as well as a decrease in antifungal costs, because at this point now you can use cheaper azole if you know the patient has Candida albicans, as opposed to what's often used as an empiric therapy of the more expensive caspofungin or other echinocandin to make sure that you cover for resistant organisms. So knowing Candida albicans allow for the use of an effective but cheaper drug. However, not all data are positive, and the study by Nancy Miller from Boston University shows that really well. And in this case, they were not able to show any sort of impact because this was being done in the absence of antimicrobial stereotype intervention. And I'm always thinking about this in terms of that riddle of if a tree falls in the forest and no one's there to hear it, did it actually happen, right? So if we spend so much money to bring all these really rapid, fancy tests, but we don't communicate these results, or nobody takes ownership of these results and do anything with it, did we actually make an impact? And in the case of Boston University, there was no impact at all on length of stay or vancomycin usage because no one was really looking at that result, right? Which then brings me to our hospital at Memorial Sloan Kettering Cancer Center. As the name said, we are a specialty hospital. We treat cancer patients and other immunocompromised hosts. And just to give you some background, or just to give you a sense of how we compare maybe to your own hospital, our inpatient hospital has approximately 470 beds, but we have outpatient locations throughout New York City, in Manhattan, in Brooklyn, Long Island. But as but also in Westchester, the surrounding Westchester County, and in New Jersey. So we have a relatively high volume of blood culture with approximately 2,500 blood culture per month. I'm going to take a second to brag a little bit about my hospital, and I should have pulled the right ranking where we are actually #1, but this is one of the cancer center, with MD Anderson, where we always switch places for #1 and #2, but we are one of the best cancer hospital, best place to get cancer treatment. When you think about the microbiology lab, we have approximately 50 FTE and divided in relatively traditional section of receiving bacteriology, virology, and we do approximately 300,000 tests a day, per year. And as I mentioned, we do approximately 2,500 blood culture per month. All right. So we wanted to look a few years ago at the option for rapid blood culture diagnostic at MSK. And so we started, it was about in 2011. So our options in 2011 was the traditional flow that we talked a little bit about before, whereby you get a blood culture, it turns positive, you do a gram stain, and then you wait and do a few biochemicals, you wait for culture to grow, and then do your census, so a few days to get your final result. In 2012, one of the options we had was to look at PNA fish, and this is the regular fish. What that did was then after you did the gram stain, you would do the PNA fish. But because that particular test took a couple hours to do, we would be batching. So there would be a batch done in the morning and a batch done in the evening. So that wasn't always ideal, but that was faster than the conventional method that we use. Finally, you would wait and get your census done. In 2013, we were able to implement QuickFISH. And with QuickFISH, that really was a game changer because you would do a gram stain, and right after you do your gram stain, you do your PNA, your QuickFISH, and within 20 minutes you had a result. And then you wait and do your census like you do with the other when you did the other sections. And then in 2015, we implemented the gram-negative PNA fish. So in 2013 and 2012, we were focusing on staph and coag-negative staph. And in 2015, we included the gram-negative QuickFISH, which is E. coli, Kleb pneumo, and Pseudomonas aeruginosa. Right. So in the next few slides, I want to discuss our MSKCC experience. And we've had two separate projects. Both have been done in collaboration with our antimicrobial stewardship group, with Susan So, Dr. So, who's the director of that section. The PNA fish, the first project, which was looking at the impact of PNA fish, Staph aureus coag-negative staph on lab flow and patient outcome, was led by Dr. Stone. And so the project was essentially to compare pre-fish era to post-fish era. So as I mentioned, in 2011, we were doing pretty conventional traditional microbiology. We'll have gram stain, positive blood culture, a gram stain, and we'll do biochemicals and then figure out what the isolate was. In 2012, similarly, we'll do a gram stain after a blood culture turns positive, but then we were batching our fish. We'll do a batch in the morning, a batch in the evening, because it took a couple hours, so it wasn't sustainable as a workflow to do it every time a blood culture turned positive. And then in 2013, we will do a gram stain, and then do the QuickFISH right away, and then report that result to the clinician. Instead of reporting a gram stain result, we were able then to report Staph aureus of coag-negative staph. So the study then looked at those three different periods of time and how that changed anything for our patient. So if you look at the patient demographic for all the 3 years, the numbers are a little bit different. Obviously, we have more patients in the pre-PNA fish era. About 196, we have 97 in the regular fish era, and then 103 for the QuickFISH. There's no really difference in the median age of the patient included in this study. And just to highlight things, anything that's bolded is something where there was a statistical difference. So of interest, there was a difference in the gender, so we had less women in the post-PNA fish in 2013, and we had more patients with hematologic cancer in 2013 compared to percentage-wise compared to 2011. And many more patients were neutropenic as a whole. So just keep in mind sort of these differences when we do the analysis of the data that we have. So starting with some of the lab workflow. So turnaround time is a relatively easy thing for us to do, right? So we looked at that pre-PNA FISH versus post-PNA FISH 2012 and 2013. And as you can see, this is statistically significant. We, in the pre-PNA FISH, it took about 49 hours from collection to result, compared to post-PNA FISH, where we went from 49 hours to 33 hours from collect to result. So a significantly faster identification of what the organism was from a positive blood culture. The time to senses, not much change because the organism still has to grow, and we didn't see any difference in hospital length of stay. I wanted to sort of bring your attention to the team impression, right? So if you look at that, when you get a gram-positive cocci cluster, clinician or the antibiotic stewardship team has to decide if it is a contaminant or an infection. So we are able to sort of record that information from the chart. And of interest, although this did not reach statistical significance, in 2013, they were able to make that judgment call that it was a contaminant in 80% of the case. So in a greater number of time, they were able to tell, because they had the correct negative staph result, that this was a contaminant, a probable contaminant. Keeping that in mind, then we looked at vancomycin use, right? And what we compared here was the duration and the number of doses that a patient got. So a patient will have a positive blood culture, and if it turns out that it was coag negative staph versus Staph aureus, they could switch them from vancomycin or not. And if you can, and as you can see, all the information about vancomycin is bolded, meaning that we saw some statistical differences in the duration of vancomycin, because at that point, then they can make a more informed decision to keep the patient on vancomycin or not. And you'll see that the duration was shorter in 2013, the number of patients with 0 doses was higher, and the number of patients with only 1 doses was lower. So everything sort of a trending in the direction of better use of antibiotics. But because, remember I said that we had less women, more neutropenic patients, more patients with hematologic malignancy, we had to do a multivariate analysis to just make sure that the difference that we observed were not due to other components. And so in this table, and this study also included a couple of our collaborators from the biostatistic epidemiology department. So they did the magic and showed that after adjusting for age, sex, neutropenia, and multiple blood culture, patients in 2013 were still less likely to get IV vancomycin because of the PNA FISH result. So very encouraging results when you're implementing rapid diagnosis. In the second study, and this was led by one of our senior technologists, Diane, and Diane looked at pre- and post-PNA FISH implementation for gram-negative rod, and this includes E. coli, Klebsiella, and Pseudomonas aeruginosa. So we implemented this in 2015, so Diane went back and looked at data from 2014, comparing them to 2015, where you get a gram-negative gram stain, you do the PNA FISH, and you're able to report to the clinician that your patient has Pseudomonas, Kleb, or E. coli, versus waiting until you have growth to do more testing. Okay. So with Diane's study, when you look at patient demographic, there was no much difference in age, gender, the number of patients with hematologic cancer or solid tumor. We even looked at inpatient versus outpatient and ICU, and the data were pretty similar in pre- and post-PNA FISH period. What was interesting, we saw actually a greater number of E. coli. I guess you really can't control for what you're going to detect when you do this type of study, but in any case, we saw more E. coli in the post-PNA FISH period, but not really much difference in the organism, the gram-negative organisms that are not detected by PNA FISH, so they're pretty consistent. So the first thing, again, looking at lab workflow and turnaround time, as you can see from this slide, pre-PNA FISH, it took about 38 hours, almost 39 hours from receive to the identification, and this was significantly decreased post-PNA FISH, where from receive to the ID, it only took 15 hours. Again, positive, very positive data. Then what Diane did here was to really take a look, not so much at like the antibiotic use, but because we were working with Dr. So and her group of ID pharmacists, we wanted to look at how often, at what point did they actually look at the result to make an intervention. So this is what we call in sort of the timing of the antimicrobial stewardship team intervention. So when you compare pre and post, from having the patient on empiric to ID, it took them about 2 hours in the post PNA FISH compared to 2.4, not quite statistically significant. From empiric to census, that was days. From empiric to the time that they received census susceptibility, it took them 2.6 days in the post compared to 3.4 days. So that was statistically significant. And when you combine these two, it took 2.5 days versus 3 days for the timing of the intervention. So when you look at the frequency, or exactly what, once they had that intervention, once they had that information to make a change, exactly how long, what did they do? So you compare pre and post PNA FISH. There was statistical difference in the de-escalation and the no change. So less de-escalation and more no change in the post PNA FISH, which all ties up with antibiotic usage, right? So to summarize the section on PNA FISH and our lab experience, as well as what's been published in the literature, the use of rapid PNA FISH improves the turnaround time to identification, antibiotic usage. It helps inform AST intervention, the antibiotic stewardship team intervention, and it is cost effective because you're looking at a specific target based on what you see on the gram stain. However, that's sort of like the other side of that coin, right? Because now some of the limitation is that you have a limited number of targets that you're looking at, and there's some subjectivity with reading some of those PNA FISH when you have to differentiate between a bright yellow or a dark green and so on. And then, unfortunately, the time to susceptibility is still delayed because we need to wait for the organism to grow enough to set up senses. So we're going to move on now to some of the nucleic acid amplification methods. And in this table, I'm listing some of the more well-known ones. So Cepheid has an expert mRNA Staph aureus for blood culture. We have the bioMérieux BioFire film array blood culture, and both of those assays are based on PCR. Nanosphere has the Verogen, and they have both the gram-positive and the gram-negative blood culture test using this multiplex gold nanoparticle technology. And then BD Diagnostics has the BD Staph aureus for blood culture that is based on PCR. And in all of these different methodology also have resistant marker, and that varies from one vendor to another. And so I'm just going to focus primarily on the large panel, including the bioMérieux film array and then the Nanosphere Verogen, to discuss those a little bit more. So target amplification. So on the right you have the film array that looks like a bread box, and I think that's the older style. And then the Verogen where you have a processor and a reader. So the film array technology, just to review, I put real-time PCR in quotation mark. In reality, the assay is based on nested PCR and then Mel curve analysis. So you do have LC green, which is a dye that binds to double-stranded DNA that is used to generate a Mel curve for every single one of the targets. And then based on that Mel curve, it makes a call of E. coli versus Staph aureus. And I'm sure many of you are familiar with this. This all occurs in this pouch. It's a sample in, answer out, and it's relatively rapid, taking about an hour to run. What's impressive about the film array blood culture is that it has 27 targets. It's a bit insane also. That's based on having both gram positive and gram negative as well as yeast. So for any from any blood culture positive result that you get, you would run this entire panel regardless of what the gram stain is. And so in reality, with this type of assay, you don't actually need to do a gram stain. So you could imagine that you collect your blood culture, and so I'm bringing back that blood culture workflow. The blood culture will be positive. You just throw it on the film array, and then within an hour or so, you have a report of Staph aureus. And you could even determine if the Staph aureus was a MRSA or not. But for the rest of the senses, you will still have to wait for the organism to grow and set up your susceptibility. The Verogen is based on this nanoparticle gold hybridization, where essentially the extraction, the amplification, and hybridization occur in the processor, which is the tall structure on my right. And then once that was done, the reader would then take the cartridge and determine what the blood culture was positive from. For a Verogen, there's a little bit more thought into it. So depending on the gram stain, you either pick the gram-positive panel or the gram-negative panel. And so if you look at the gram-negative panel, it has the more common organism that we see, but also include ESBL and CRE markers, so that's pretty cool. And when you look at the gram-positive, you have the enterococcus, the staph, the strep, but you also have listeria and some of the resistance marker, including MEK and the vancomycin resistance. So if you look at some of the workflow for the Verogen blood culture, and this will be similar for the Cepheid and the BD genome, that's why I put some examples there, you still need to do a gram stain to determine if you needed to run the panel or not, or which panel you should be running. And this is a mistake. It should have been a preliminary report would have Staph aureus or E. coli, not GPCC. And again, if it was an MRSA, you still have to run the panel for final senses. Right. So when you look at data, this was a study from Raquel Martinez from a few years ago, looking at the accuracy of QuickFISH, moldy, and Verogen. So we didn't talk really about moldy, but that's another option. And when you look at the accuracy, QuickFISH and Verogen, the blood culture gram-positive, were very similar, including the range. And this is primarily for monocrobial infection. When you have polymicrobial infection, that becomes a bit challenging, especially for the moldy. Additional study from Europe also showed that when you compare Verogen and film array to conventional method, the time to AST was better. There was no difference for the time for the blood culture to come up positive. That would still take about 40 hours in this particular study. But then when you look at gram stain to AST, with conventional method, you had approximately 70 hours before you could get your senses. But with Verogen and film array, you had about an hour or two to get the ID, and then the total results were done in 40 hours. So saved a whole 30 hours, which is very impressive. So to summarize the NAT, the use of this large NAT panel improves the turnaround time to identification. It gets to an hour to 2 hours, depending on the panel that you use. It improves antibiotic usage because you can implement AST much faster if you know, for example, that a patient has a CRE in the blood. It informs AST intervention, and it is also automated and objective because PCR, it's a sort of yes/no answer that you have to look at an instrument for that reading. The limitation is, although you have 27 targets, for example, with the film array, that doesn't include everything that is ever positive in the lab. So you still need to have other methods of identification around. For some of those, the cost must be so high that if you have a really high volume of blood culture and a lot of positive, that may become prohibitive. And the time to susceptibility still remains because you still need to get the ID, the organism to grow. Which then brings me to some of the newer methodology that are available, and the one that recently received FDA approval is the Accelerate Pheno system from Accelerate Diagnostics. And the cool thing with this platform is that you do get an ID in 90 minutes, but then 7 hours later, you get your susceptibility results. And so the Accelerate Pheno system can do gram-positive, has a gram-positive panel that includes Staph aureus, Staph longdunensis, coag-negative Staph, the enterococcus, and strep, But in addition to identifying these organisms, you also have sort of a reduced panel of drugs that are commonly used as primary drug for these organisms, and you end up with an MIC similar to what you would do with a microscan or a Phoenix or a Vitek instrument. And in addition to that, we have some of the resistance marker. They also have Candida albicans and Candida glabrata, although they don't have antifungal marker or antifungal testing done. And then for the gram-negative, again, the E. coli, the Kleb, the Enteroproteus, Citrobacter. So again, the more common organism, and a few more antibiotic there where you get a MIC that then helps you. So thinking about is 7 hours is enough time to basically impact patient care. We're going to finish up with culture independence. So as I mentioned, this is sort of the holy grail, right? That's where we all want to be, being able to take that specimen and do testing directly, similar to what our chemistry and hematology colleagues do. And so at this point, T2 magnetic resonance technology is sort of the only player that is FDA approved for that particular option. So things to know about T2, there's no DNA extraction, so you don't lose target, which is good when you're looking at sepsis. Sometimes you don't have that many organisms. The LOD, and this relates to the Candida panel, ranges from 1 CFU, is approximately 1 CFU per mil when you compare to blood culture where you need at least 100 to 1,000. It's sort of an indirect detection of the target because you are looking at the displacement of water around the amplified target that you have rather than really that particular target. So you're measuring a change in the microscopic environment. So the workflow for T2 would be you get 2 ml of sample, you lyse the cell, you remove the soup, you lyse the yeast, you do your PCR, and then you add your hybridization and then detect it. And so the detection is this amplicon-induced agglomeration of superparamagnetic nanoparticle. And I dare everyone to say this multiple times, but the technology works, and there's been enough study there's been a couple of studies showing that. So this is the current panel where they have albicans, tropicalis, parapsilosis, cruzia, and glabrata. And this study that was published in CID showed that the sensitivity ranged from 1 CFU to maybe about 30 to 100, but the sensitivity was high. And when you look at the overall accuracy, it was about 90%, but it ranged from 96 for C. albicans to 91 for C. glabrata. So more study needs to come to sort of support that, and I think there's been enough presentation at the recent ASM that support that this works well. So right now you'll have your sample, you do the T2 test, and then you'll have a final report of Candida albicans. But does it mean that we're not using blood culture anymore? Probably not, so we'll have to figure that part out. All right, so when you think about the newer platform, there's really some cool things that are coming down the pipeline. So the Accelerate show that you can combine ID and AST and reduce that to 7 hours. The testing directly from blood, ST2 Diagnostics does it, is pretty cool as well. However, we still need to see study on impact on patient outcome, and those haven't, there's been a few, but not too many. So we'll have to keep an eye on those technology and see how they impact patient care. So just to conclude, sepsis remains an important symptom, and it is associated with high cost and high mortality. As we discussed, it's the most costly syndrome that we have. It costs about $20 billion onto our healthcare system, and it also has high mortality, as shown by Rory's stories. So prompt identification remains very challenging because sometimes many things can look like sepsis. So the clinicians have to be aware, but the laboratory has to use some of these rapid and sensitive diagnostics to make sure that once we have a positive blood culture, we are able to at least give that ID within 20 minutes if you're using PNA FISH, or 2 hours if you're using like the Verigene. Okay, so those were the learning objectives. So I hope that you guys now are able to define sepsis using the more recent definition, and also discuss some of the laboratory methods and the benefits that are related to using those for the rapid diagnosis of sepsis. So I want to say thank you for your time, and I will be happy to answer any question that you may have.
Thank you, Dr. Babady, for that informative presentation. It's time for Q&A. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window, type your question into the box that appears on your screen, and click on the Send button. We'll answer as many of your questions as we have time for. If we are unable to get to your question, Dr. Babady will follow up with you via email after the presentation. So let's get started. Our first question is, with the increasing number of multi-drug resistant organisms and QuickFISH only providing pathogen identification, how do your clinicians use the pathogen ID for guiding treatment options without resistant markers or susceptibility?
That is an excellent question, and if you look at some of the large panel, they do have resistance marker. However, that is still limited. So the approach that we've had at Sloan Kettering is then using the institutional antibiogram, and that's why we work so closely with our antibiotic stewardship team to determine what's the empiric therapy and sort of what de-escalation or escalation can occur based on the ID. And that's because we have an institutional knowledge of how much resistance that we see. But definitely, ideally, we would be able to get these senses, not just marker for one or two things, but the actual susceptibility results relatively quickly so we can make more informed decisions. But those are excellent questions.
Great. Thank you so much for that answer. The next question is, do you run QuickFISH on all positive patient blood culture bottles or just one bottle per set?
Yes, so to be, again, a very good question, and to be cost effective, especially at a hospital like ours where sometimes patients may have, I'm not joking, sometimes 10 blood culture collected in one day. So our approach has been to run the PNA FISH on the first positive blood culture for that episode or for that day, unless the morphology is different, then we will run it on another PNA FISH. So it depends. Essentially, we do it on the very first one that comes up positive only. And if the morphology is the same, then we will not repeat it.
Great, thank you. The next question is, how specific are the FISH peptides? What percent of sequence mismatch can they tolerate in the target RNA and still give the fluorescent signal?
That's a very specific question, and I think based on Upgen and AdvanDx data, I think they said about one mismatch, one base pair mismatch, and they will still be binding. We know that when you look at the package insert, they have known organisms that are known to cross-react. So there is the specificity is not like 100%, but those organisms tend to be so rare that we don't tend to see them very much. But that I think 95% and above is what we've seen. And when we do our validation before we go live with a test, we have actually specificity that are closer to 100%, at 99%.
Okay, thank you so much. The next question is, any comparison info between MALDI-TOF and rapid PNA?
Yes, so I have to start by saying, so MALDI-TOF on direct blood culture obviously would be an off-label use of the technology, because that MALDI-TOF technically has to be used on an organism that's growing on a plane. However, many people using like the sepsis typer, for example, have done study looking at using MALDI-TOF directly from a positive blood culture. So the study that I quoted, I quoted in the presentation from Raquel Martinez, I think was done at the University of Washington. And if you look at that study, the accuracy of MALDI was a little bit less compared to PNA FISH or I think at the time they did the Verigen assay. And so it works. We've tried that. It works most of the time. So the accuracy is not that great. And if you have polymicrobial infection, which do occur, then your accuracy goes down even more using MALDI-TOF compared to very specific tests like PNA FISH or FILMARRAY.
Great, thank you so much. We're almost out of time, so we'll wrap up with one last question, and that question is, between PNA FISH and multiplex, which one will you recommend for a small lab to diagnose sepsis?
So I guess the definition of a small lab, I give you like the example of the size of our hospital, and we chose at this point to still use PNA FISH versus the big panel because we know what the percentage of what type of organism we isolate, and it's so simple to do a gram stain, and it's so simple to do the PNA FISH that works for us. And I think for a small hospital, not to incur that additional cost of doing a panel for every positive. When you know, for example, you have gram-positive cocci, you don't need to do a panel that includes any coli. I think that would be my recommendation. I mean, we do molecular testing for respiratory virus, and with that, you know that you have no clue. You just know the patient has a swab that is suspected to have a virus, for example. So there's nothing that can guide you there. But with a blood culture, the fact that you can do a gram stain, my preference is for doing more targeted approach to the identification, which then would include PNA FISH or maybe like a Verogen panel rather than a super extensive panel. But I think you take into consideration additional components, like can you afford it, like how many positives do you get to decide of sort of what the best approach is for you. But this is what we had decided to do at Sloan Kettering. Hopefully that helps.
I would like to once again thank Dr. Babady for her presentation. Do you have any final comments?
No, I mean, my information's there. If anyone has questions or would like more information or data on some of the study that we have done and some of the approach that we've taken, I'll be happy to answer them. So just feel free to contact me.
Thank you once again, Dr. Babady. I would also like to thank LabRoots and OpGen for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through December 15th, 2017. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us. We hope to see you again soon. Goodbye.